Hello, welcome to the Conquer Chiari 2022 Symposium. My name is Jeff Greenfield. I am a pediatric neurosurgeon at Weill Cornell Medicine and Columbia Physicians and Surgeons. My talk today will be focused on the diagnosis and management of Chiari malformation in toddlers, children, and adolescent. I'd like to thank the Conquer Chiari Foundation, Rick Labuda, for inviting me. I'd like to thank all of the other panelists and presenters throughout the whole course of the symposium. And of course, I'd like to thank all of you who have taken the time and energy to educate yourself and to become more familiar with all the various nuances and pathophysiology of Chiari malformation. The way I've chosen to think about Chiari malformation and present it to my patients when I see them in the office, and to talk about it scientifically in forums such as this, is to think of Chiari in a broad sense as really a syndrome of compression of the cerebellum and medulla. This is easily encapsulated in the title Cerebellar Medullary Compression Syndrome. It's really an algorithm for the diagnosis and management of Chiari malformation in all of its forms. And the way I've organized it is outlined here in this very convenient infographic here, with the algorithm of 6 different distinct subtypes of cerebellar medullary compression, each one with its own heading and with the very easy to remember moniker CHIARI. And so the 6 categories, starting in the lower left and working around in a clockwise direction, are compressive, hydrodynamic, iatrogenic, acquired, retroflexed odontoid, and instability. And throughout my talk today, I'm going to break it down one by one to explain what these pathophysiology look like, how we identify them, how we work them up, and how the surgical nuances may differ for each of these categories. And hopefully by the end of the talk, you'll have an understanding how they all fit under the same rubric of cerebellar medullary compression syndrome, but each with distinct nuance and subtle differences in how they should be managed in children. I think it's important whenever you're giving a talk to a diverse population just to take into account what we're trying to do here. And so as neurosurgeons, we have a unique responsibility in the Chiari community to understand the differing ways in which Chiari may present and the different ways that Chiari may have connotations to different populations of children and complex adults with congenital disorders. The understanding is really critical because it then defines what further testing is necessary, which referrals to generate, and what surgical nuances to consider. And this is the way we can tailor responses and surgical opinions to maximize symptom relief while minimizing complications. And that's always the balance that we're thinking about. This is based on probably over 1,000 patients that I've seen within my practice, the way I've broken this down into the 6 categories. And so I hope that by sharing this with you, the Chiari community of patients, caregivers, and healthcare providers, that maybe we can continue this conversation and open up ways of discussing this in different ways so that we can move the conversation forward. The urgency probably doesn't need to be outlined to this group. People who are here and spending their time learning about it know that there's maybe no more frustrating patient population within which to predict surgical outcomes, and there's a big effort within the Chiari community to understand and to become better at predicting outcomes than those with Chiari malformation. And so this radiographic anomaly has become more and more appreciated, but it has in some ways created more and more confusion and frustration. And so that's why I've tried to create this unified approach towards this syndrome. So again, this is how I've outlined it here: compressive, hydrodynamic, iatrogenic, acquired, retroflexed, instability. And I have examples both in cartoon form and in MRI form here. And you'll get a better appreciation for what these look like when we go through them one by one in a little bit more depth and a little bit more zoomed in view. So I like to start with the compressive pathophysiology because I think it's the most straightforward and maybe the one that people are most comfortable understanding as sort of classic Chiari. This is the congenital hypoplastic posterior fossa, meaning that the back of the skull has been actually malformed. It is either too small or too horizontal in the case of children with achondroplasia. Whatever the underlying etiology, the foramen magnum, the space at the base of the skull, is too small, and the contents of the posterior fossa become compressed. Sometimes they herniate, sometimes they get compressed against the brainstem, but in any case, the symptoms are from focal compression at the cervical medullary junction. And these are typically children who can undergo a very standard decompression, either with or without duroplasty, but particularly a population in which I do consider dural sparing to be a really valid option, particularly in the very young populations. An example of a very classic compressive symptomatology, and these are examples I've been just pulled from my practice over the last 6 to 12 months. This is a 2.5-year-old male with occipital, back of the head, and neck pain. Had a sleep study that was abnormal, and mom was really struggling getting the child to take proper oral intake. Didn't really have anything focal on examination, as is often the case with these young kids, and had some delay of milestones. The rest of the neuroaxis didn't show anything. There was no hydrocephalus and there was no syringomyelia. And this is a child where, after consultation, we made the decision to do a bone-only decompression. And you can see, comparing the left image, this is an MRI scan in the sagittal plane, the cervical medullary junction, you can see is compressed right at the level of C1. And here, just by removing the arch of C1 and a little bit of the suboccipital bone, you get this nice cushion of CSF there. And it would be an understatement to say that the family was thrilled with the outcome here. And this is a really minimally invasive procedure. Downsides are that durability is still questionable, and some of these children will have to have further surgery as they get older due to bony regrowth or growth of the brain and the cranium, and may require even a duroplasty as they get older. But certainly for a young child to have a 90-minute surgery and to have a whole new quality of life is really, that's the type of risk complication balance that we look for, and the assessment in these children is often very favorable for bone-only decompressions. The hydrodynamic pathophysiology is also one that people are often really familiar with, because it's the one where CSF flow is the center and the star of the show. You can see on the infographic here up in the right-hand corner the very classic dilatation of the central canal coming from the obex down into the cervical spine, and the classic picture of a syringomyelia or a syrinx cavity in the cervical spine there. And these are children, adolescents, young adults who are evaluated maybe with a little further nuance. They'll often get cine imaging, true FISP cine imaging. Ophthalmology plays an important role for us to look for evidence and signs of papilledema, and sometimes even more advanced testing beyond that. The most important thing with these children is to always treat the hydrocephalus first, and we do go to exhaustive lengths, and should, to make sure that there is no underlying hydrocephalus at the root cause. This is a major reason why I believe there are postoperative complications such as CSF leaks, that being unrecognized intracranial hypertension or elevated CSF pressures to some degree. And so always treating the hydrocephalus first is a tenet that I really espouse, and I think is important for all patients to hear, whether that's with medication in older patients with weight loss, or sometimes even with an endoscopic third ventriculostomy or a shunt. Treating the CSF problem before treating the Chiari is always going to be relevant. And we'll see further examples of that later in the talk in some of the other sections as well. Most of the time I advocate for a duroplasty in cases where there is a syrinx. Certainly there are examples of syrinxes resolving without duroplasty. They tend to take longer to resolve, and depending on the symptomatology, whether it's scoliosis or symptom management, time may be important. But certainly they're both considerations. I do tend to think that a duroplasty is more effective and faster acting to resolve syrinxes in these patients, and I'll show you some examples of those here. So this is a really dramatic example in the top row here of what we call syringomyelia and syringobulbia. So this is actually, it looks like the spinal cord, but there's actually an expansile syrinx filling the entirety of the spinal canal, and in all likelihood actually expanding the spinal canal, which makes this even more dramatic. The diameter of the canal, based on the size of this, has actually been enlarged based on the fact that it's been there since this young lady was probably a young child. And the syrinx extends all the way up into the brainstem too here, which makes it incredibly scary in terms of basic autonomic functions such as breathing and heart rate and blood pressure, sleeping, swallowing. So even though this child was remarkably asymptomatic, really came to presentation almost by accident with leg pain, it was pretty easy to make the recommendation that this needed to be treated before something devastating happening. And so this is a classic picture of a very small targeted decompression. Just about 15 millimeters or so of the suboccipital bone and the C1 arch are taken off. A duroplasty is created. The fourth ventricle is explored. In this case, there was a large web occluding the obex and the fourth ventricle outflow. By lysing that, you can see here very quickly, within 3 months, the syrinx is dramatically decreased in size. You can see just how large it was now in comparison. And then in the bottom here, maybe a more typical, less dramatic, but more common presentation of Chiari, where there is really extensive herniation, in this case down, way down, almost the tip of C2. Very small syrinx you can see visible here, but much more classic Chiari herniation pattern here. It looks like it potentially could be Chiari 1.5 with a little bit of a kink here at the base of the medulla. Again, a very small targeted craniectomy is all you need, about 15 to 20 millimeters in this case. The arch of C1 is removed and a duroplasty is created, and syrinx immediately disappears. You can see the tonsils have been reduced in size, and there's now a nice pocket of CSF. So that's a really classic picture. One maybe more dramatic and one classic of how the hydrodynamic pathophysiology related to Chiari malformation is typically treated in my practice, and I think in a fashion similarly across the country. Just a quick little sidebar here on syrinx. It's something that we study and have published a bunch of papers on recently, and that is to emphasize that most patients do show radiographic improvement in their syrinxes. Well over 90% of the patients have medium, significant or complete resolution in their syrinx size. And so for patients who haven't had good results in their syrinx, I think it's always worth a second look and an opportunity to get a second opinion to see if there's something that's been missed. Again, because this is really, a dramatic change in the way we manage Chiari and syrinx from 25 years ago, and many of our teachers were training. And so this is something that we feel like we should be able to treat in the vast majority of patients. And this is to come back full circle, still in the hydrodynamic pathophysiology realm here, but here's a patient who has clear herniation of the tonsils down below C1 here. But remember my dictum here of treating the hydro first. And so this is a child who definitely has elevated ventricular size. Whether or not they have elevated pressure, you can't tell a priori without some testing here. But someone who was shunted as an infant, clearly, at one point had a problem. And so before jumping to decompression of the cervical medullary junction and doing a classic Chiari decompression, we took advantage of the fact that we thought underlying CSF pathophysiology was at play here. And instead of revising the shunt or doing the Chiari, we did an ETV, which is a minimally invasive procedure where we divert CSF flow. You can see a couple of still shots here through the floor of the third ventricle with a tiny little 3 French catheter, just a couple of millimeters in size to restore flow. And by doing that, the hydrocephalus is treated and the cerebellar tonsils ascend back into the brain, essentially treating the Chiari without Chiari surgery and allowing complete resolution of symptoms. So just wanted to share an example there of the treat the hydrocephalus first dictum in action. The iatrogenic pathophysiology component here is one that I was not trained in and only became familiar with as I started seeing more and more consults from around the country on patients who had had failed surgery and trying to figure out what was going on here. Why was there so much variation in what people were doing? And so for these patients, they could have really over-aggressive decompressions. Sometimes I see decompressions where they're so small you can barely believe that surgery was done. Focal tethering or scarring, like I've shown over here, a clear CSF leak where the dura has a huge wide opening here and a pseudomeningocele. Here's an example of a really large decompression here. And so for each of these patients, the workup is a little bit different, but I'd like to get a 3D reconstruction to really see what's going on. Sometimes the MRI scan is not the best way of looking at the bone. I'd like to rule out underlying causes that might have been missed the first time, like CSF leaks or intracranial hypertension. And I'll go to some, extreme lengths for patients where we really need to figure out what's going on, including doing ICP monitoring and doing all types of revisions to reconstruct the proper anatomy of the posterior fossa and restore proper CSF flow. And sometimes it takes a little bit of work, but we've got some beautiful examples of how this can work if you're willing to put in the effort to really figure this out. This is an example that I show of a young girl who really had every complication under the sun, done at an institution where they just didn't have a ton of familiarity with Chiari malformation surgery, and you can see a really, really impressive size syrinx here. I don't even have the initial scans here, but this is worse than it was before surgery. And the reason why they came to me with such a bad condition here, you can see she was in a wheelchair, incontinent, had withdrawn from school completely because of her condition, was because she had had a leak from surgery and developed hydrocephalus and then needed a shunt. And by the time she came to see us, was in this significant disarray. And you can see on the previous scan, I'm sorry, on the previous slide, well, it's not worth going back, but I can assure you here that decompression, which is now shown here filled in, was probably 4 or 5 centimeters in height, which is an enormous decompression. And in fact, hadn't actually adequately addressed the most focal part of the compression, which was down here at the brainstem. And so we made a custom implant to fill in the defect and then remove the proper amount of bone at the foramen magnum, opened up the CSF channels and placed the stent in between the fourth ventricle and the cervical subarachnoid space. And you can see complete resolution of the syrinx, restoration of normal CSF flow, and posterior fossa volume. So really a tour de force, and very painful for the family to go through and for us, and but extremely gratifying. She's almost a completely normal young girl now. Did need to go on and have scoliosis surgery several years later with one of our orthopedic colleagues, but so many things can go wrong, and sometimes they spiral out of control. And so unfortunately, this iatrogenic pathophysiology group has become a larger and larger component. I think speaks to the importance of going to a high volume center and getting multiple opinions on pathology before jumping into surgery, unfortunately. The acquired pathophysiology, this is the A of Chiari, I think is probably more common in older children and in young adults, but I think equally important to consider in some patients who have connective tissue disorders or who have failed traditional management. And these are patients who have an acquired Chiari malformation. So that means that this is not a primary Chiari, but rather something that has occurred over the course of the child or young adult's life to lead to herniation of the tonsils. And the 3 most common things are tethered cords, CSF leaks, and intracranial idiopathic hypertension. And each of those get worked up in different ways. On the left here, I show an example of a patient who I thought had a CSF leak and could not be found on MRI scans. So we put it in an ICP monitor, and sure enough, this patient had intracranial pressures of -9, laying down in the flat position, and went down to -15 when they stood up. Received a myelogram, and in fact the CSF leak was found. But the examples here run across the board. So depending on what you think the physiology might be leading to the acquired herniation, that workup evaluation algorithm might be slightly different. And the medical management, surgical management is all going to happen before Chiari decompression. That would be a last resort and is usually not necessary in some of these situations. So I'll show an example here. This is in the top row is a teenager who presented with arm numbness. Never had a headache at all, but when they were in the office, definitely had some abnormal neurologic signs. Clonus is hyperreflexivity, indicative of spinal cord dysfunction, and had real bad back pain that she in fact hadn't even told her family about until we talked about it in the office. So we completed the rest of the neuroaxis, and in fact she had a very complex form of what we call congenital dysraphism. This is a lipoma or lipomyelomeningocele, where there's a big piece of fat that is continuous between the subcutaneous tissue and the lumbar and sacral portion of the spine and the distal part of the spinal cord, which never formed properly. And so the herniation of the back of the brain was actually not a reflection of something that she was born with, but rather the reflection of constant tugging as her spine grew. Tension on the lower part of her spinal cord actually prevented normal development of the neuroaxis. And so her surgery was actually a release of this. This is essentially a complex tethered cord scenario. We see very, very mild tethered cords. We see occult tethered cords, simple fatty phylums. Those are sort of on the left end of the spectrum. This is on the right end of the spectrum in terms of the severity. But it really speaks to the fact that you've got to look at the entire neuroaxis and you've got to rule that out. In fact, if we had done a Chiari decompression on this young lady, I'm quite sure she would have gotten worse. So we just would have been creating a larger defect through which her cerebellum might have herniated. On the bottom row here is a complicated patient of mine that I think is really important to show because it highlights some real errors in care. And you can see here on panel A, this is a very clear syrinx in the upper cervical spine, and then what we'd call a pre-syrinx throughout the rest of the cervical spine. It actually goes all the way down into the thoracic spine. And you can see very clearly this patient had a Chiari decompression surgery. And in fact, the Chiari decompression surgery not only didn't work, it actually made the syrinx larger. And so the pre-syrinx turned into complete syrinx. And you can see also pretty clearly here, the reason is that the decompression not only didn't work, it potentiated the herniation of the cerebellar tonsil, so basically creating a larger hole. And what this told us was that there was actually something going on that was pulling the brain down. And in fact, this young lady turned out to have what's called a CSF venous fistula. It's essentially a complex CSF leak in her thoracic spine that required tiny little decompression in the spine, a clip on a single nerve root, and 3 months after that surgery, you can see that the brain returned back into the cranial compartment, and as a result, the syrinx completely resolved without further surgery at the cervical medullary junction. So the primary problem was actually an acquired pathophysiology of a CSF leak. So whether it's intracranial hypertension, hypotension from a leak, tethered cord, acquired pathophysiology is incredibly important to think of within the context of this cervical medullary compression syndrome. The last two parts of this algorithm are retroflexed odontoid and instability of the craniocervical junction are probably the most complex. They're less common in the young children, although we have had to treat this in children as young as 2 or 3 years of age. More common in the young female teenage population with comorbid Ehlers-Danlos syndrome, and so certainly something that we see a fair amount of and really have to think about. These are patients who either have a retroflexed odontoid, which you can see in the cartoon in the upper right-hand corner here, leads to ventral compression of the brainstem as opposed to dorsal compression, which is the more typical type of compression from Chiari malformation. They often will have cervical spine anomalies that go beyond just that brainstem compression there. And they get a completely different workup. This is not a hydrodynamic problem. This is a compressive problem and sometimes a dynamic problem. And so depending upon the physiology with which they're presenting, some of the workup will include flexion extension imaging, either x-rays, CTs, or MRI scans, sometimes upright if possible. CT scans become part of the algorithm now, whereas they're very rarely used in the other physiologies. And then looking at the physiology of the brainstem, whether that's through tilt tests, Holter monitors, sleep studies, swallow studies. Again, it depends on what the presenting features are of those patients' symptom complex here. And these patients may end up with a more complicated surgery as well. And so sometimes an odontoid resection is needed, sometimes just an OC fusion is needed, and sometimes a combination of the two. And I'll show you sort of an example here. Those are just some examples of a failed sleep study and a failed ENT evaluation. So this is a complex MRI scan, a lot of stuff going on. This is essentially a completely kinked brainstem, a herniated cerebellum, and lots of compression at the cervical medullary junction, 2 centimeters of herniation. But in reality, the herniation, while it's severe, is not actually the most impressive part of the physiology here. The impressive part of the physiology is the fact that the skull base is flat and the odontoid is retroflexed, and the tip of this odontoid has a pannus on it, and that whole complex is compressing the brainstem from the front. And so sleep apnea and aspiration, like I showed on the previous slide, grossly abnormal neurologic exam, dysmetric, hyperreflexic. And this is a type of child, this is I think a 14-year-old teenage boy who really needed a 360-degree approach, in my opinion, whereby we decompressed and fused from behind, and so created all of this room, the cervical medullary junction dorsally, and then also did an endonasal, so a minimally invasive approach through the nose to get to the odontoid. And you can get all the way through the sinuses, all the way to this bone, and we drill this bone out with a little camera and relieve that compression ventrally. Sometimes you don't need to do that if you can just realign the spine properly, and sometimes you need to do both. And so this is a situation where retroflexed odontoid pathology was really causing the majority of the compression and was not reducible by realigning the spine, and so they needed a decompression, fusion, and an odontoid resection. And this child did remarkably well, a fantastic kid, was back playing sports 6 or 12 months later, and this is probably, maybe 8 or 9 years later now, and I think he's fully employed. He's a licensed electrician in New York City and doing fantastic, and I still continue to see him in my practice. And the last part of this is instability of the craniocervical junction. This is instability and excess movement without that gross compression. This is, again, a really complicated type of child to figure out, but it involves a lot of the same types of evaluations, including those dynamic imaging modalities where we're looking to see if there's excessive motion at the craniocervical junction or instability due to Ehlers-Danlos or other underlying hereditary conditions involving collagen disorders. And so these are children who do not really need decompressions. They just need to be evaluated for stability. And so sometimes the collar trial ends up being the most important tool that I have in my armamentarium. And that is basically seeing whether or not eliminating the movement by putting in a rigid collar, either an Aspen Vista or a Miami J, can eliminate the symptoms. And this example is the 17-year-old girl with EDS, sort of a classic patient who has all of these issues: headaches, pain, dizziness, all of this autonomic instability, absent gag, hand numbness, and everything goes away in the collar trial. Then this is a good candidate for OC fusion. Typically, we'll try everything under the sun before doing this: conservative management, strengthening, collar use intermittently. But ultimately, children who end up needing to go through this do exceptionally well. Here's an example of an OC fusion construct, what it looks like actually in the operating room. This is cadaver bone used to augment the fusion. These are screws that are attaching an occipital plate down to screws in C2 to essentially eliminate the movement between the cranium and the upper cervical spine. And these patients do really well once they've healed, but it's a big operation. It takes a long time to heal, and the complication rate, infections and non-unions, is not insignificant. And so this has to be thought of as, a surgery of last resort for patients who don't really have any other options. So altogether here, this is an algorithm that I use within my own practice that begins with structuring the intake in a very specific way, evaluating a specific way, and doing specific types of imaging. And that leads to very tailored surgical approaches. No matter what they have underlying their cerebellar medullary compression syndrome, they fall somewhere in this rubric here. And hopefully I've been able to share this algorithm with you guys. Anyone who's out there and has been confused in the past, hopefully this will not confuse you further, but provide a framework within which you can say, I think I'm more in that category. This is the type of workup I need, or I think I'm actually more a hydrodynamic patient. So hopefully patients and healthcare providers will benefit from this. And whether it's for talking with patients, talking with your family members, trying to describe it to your physicians where you live, I think this can really help in developing a really complex team of providers who can work with you around this. Ultimately will be the most useful way to move your care forward in a meaningful fashion. So I really want to thank all of you for taking the time to spend part of your precious day with us. I'd like to thank Rick again and the Chiari Foundation for inviting me to the symposium this year. And hopefully I've given you some insight into what the cerebellar medullary compression syndrome is and given you an opportunity to understand and integrate your own care or your family members' care into this algorithm for what has largely been referred to as Chiari malformation. Thank you very much, and I look forward to speaking with you during the panel session later.